All right. Well, happy day. Good afternoon to everyone, wherever you are in the world. My name is Denise Fairchild, and I am the moderator for today's conversation. This group will be talking about the role institutions play in reshaping systems. Let me first start by saying that was an amazing introductory plenary that Dr. Jones provided us and gave us a lot of rich information that we hope to explore more in this panel discussion or this one-on-one discussion with Gary Cohen. We're going to go deep into all these issues of race, climate, and health, and the role institutions can play in finding solutions. I think we're going to be more solutions oriented now that we've gotten the framework and the challenges that we face. Let's talk about what some of the solutions look like. So let me tell you how we're going to format today's conversation. I am your moderator. I'll give you a little more about my background in a minute. And I'm going to be using an Oprah style informal conversation with Gary Cohen, who is the co-founder of Healthcare Without Harm, and he will introduce himself as well. So it'll be a one-on-one chat with Gary, and we'll talk together about our effort around anchors and resilient communities and how that's addressing many of the issues that we were raised in the plenary. And after a little bit of conversation with Gary about ARC and other policies and practices that are taking place across health institutions in the United States and across the globe, we're going to open it up to invite you in and to have a conversation and answer your questions and share your own best practices about addressing systemic racism, embedded racism, individual racism, to really create healthy communities and climate resilient communities. So that's what we plan to do. And I think the first 15 minutes will be our conversation, and then we'll throw it out to you. So let me just start by letting you know a little bit about me, and then I'll open it up and pitch it to Gary. Why am I here? Why I'm in this conversation? I'm not a health practitioner. I'm fundamentally a community developer. I'm an urban planner by background and spent 40 some years actually working in the field of community development in South Los Angeles, working alongside other community organizations, addressing some historic and horrific market failures in South LA. I've been building affordable housing and working with groups to build affordable housing because the housing market failed us. We had no affordable housing in over 20 years before we actually started developing the capacity of communities to build our own housing. We had huge failure in the banking and credit and housing market, failed us when housing developers refused to come in and build housing. Huge retail market failure, had no stores. It was 30 years before we got more than one supermarket in our community in South Los Angeles. And it was a struggle, it was a fight to bring in retailers to think that people in South LA ate food and deserved quality food at decent prices. We have huge failure in the banking market, from disinvestment to redlining, all of the issues that make it difficult for us to start businesses, to grow businesses, to send our kids to school because we couldn't get educational loans. So we had to be our own community builders, essentially. And we were doing it alone. We were doing it by ourselves. And it was a struggle. It's been a struggle. We have a different challenge now. The challenge of divestment has been replaced with the challenge of gentrification. As they say, you have to be careful what you ask for. You know, we say we want investment, and as soon as we get investment, our communities are now being pushed out of these communities that we've lived in historically. But the point is this: I recognize that we cannot do this alone. That we have to figure out how we bring institutions and corporations back to the table in a way that work with community, not working against communities, to rebuild a healthy community. My initial work was with community colleges and trying to get these institutions to not only educate and train people for jobs, but to also turn out faculty, to turn out their staff, to turn out their students, to work in these communities and helping businesses put menus together and do business planning and helping schools educate their young people on computers and all kinds of resources that these colleges had that could turn a community around, where community organizing and community planning, community development efforts would have a partner. That's when, in my work now at Emerald Cities Collaborative, president and CEO, started thinking the same kind of approach was needed to address issues of climate change, building climate resilience, building healthy communities, building economic opportunities. And I reached out to this guy named Gary Cohen. I know nothing about health institutions. I know community development as an organizer, planner, and developer. And I said, Gary, you're the man. You're someone who's lived over 20 years working with health institutions to help them provide health care and do no harm in the process. Building climate resilient, healthy builds economic opportunities. So we embarked on this effort, and I'm going to ask him to talk about it, called Anchors in Resilient Communities, to turn health institutions outwards, not only to build sustainable health institutions, but also to use their financial, their intellectual, their social, and their political capital to build community climate resilience. We call community health, community wealth, and community climate resilience. So we've been on this journey. It's been an amazing journey, and I think it really deals with all of the issues raised by Dr. Jones about how do we change systems and structures and the foundations and the root causes for unhealthy populations and individuals. And so with that, I'm going to ask Gary to tell us a little bit about himself, his organization, and what he's been doing, and what is ARC? What does that have to do with anything that we've heard this morning?
Thanks, Denise, and it's always a pleasure to share a real or virtual stage with you, and it's been a great partnership. So I appreciate that. I have been involved in the environmental health and justice movement for 35 years, and I started with a national organization that was helping communities fight incinerators and toxic dumps, and they were living down the street from petrochemical plants and other polluting factories. And a lot of these folks had no money, no technical assistance, no technical expertise, no political clout. They were taking on some of the biggest companies and powers in their community, but they had enormous tenacity and bravery because they were defending their kids' health. And to me, that was so powerful. And I felt I needed to be involved in working in solidarity with those communities. And along the way, we started to learn that the healthcare sector itself was a major polluter. When we started Healthcare of the Harm, there were 5,000 medical waste incinerators all around the country, attached to most hospitals. And healthcare was the largest source of dioxin emissions in the country and a significant source of mercury emissions because of all broken thermometers winding up in the incinerators, going out into the air. Anyway, we said, the folks that we were working with said, how are we ever going to turn around our society if the very sector of our economy that's supposed to be about healing is itself poisoning people in its ignorance in service of their medical profession? So we said, we gotta get the healthcare sector on our side. We have to get them to understand the links between fossil fuels and health, toxic chemicals and health, industrial agriculture and health, transportation and health. There was really almost no knowledge. And our analysis, which has even become more powerful in our thinking, is that you can't have healthy people on a sick planet. That in order to create the kind of healthy communities that Dr. Jones and all of us want, that we have to address fossil fuels, toxic chemicals, and industrial agriculture as a root wound that exacerbates all of the racial inequities and injustices that we've been talking about. So healthcare is 20% of the US economy. Who better than healthcare to leverage all of its assets to heal the economy, to heal our addiction to fossil fuels, to heal our addiction to toxic chemicals so that kids are not born with toxic chemicals in their bodies, like ticking time bombs, waiting for cancer and learning disabilities and birth defects and other things to show up. That the food system doesn't manufacture disease more than it manufactures food. Like, we need healthcare, which has this Hippocratic oath to leverage all of its power. And that's what ARC is about. It's about having healthcare institutions leverage their purchasing power, leveraging their investments, leveraging their workforce development to address the cliffs that Dr. Jones was talking about, and move upstream and not just deal with individual health, but deal with community health and deal with planetary health. Healthcare and all of us need to be operating at 3 levels: individual, community, and planetary. We can't afford not to at this point, because the climate crisis is the force multiplier, as is COVID, that demonstrates all of these inequities. It's a multiplier. So the thing that ARC has done is to say, okay, we've held the hand of hospital systems for 25 years. We've built trusted relationships. We've not blamed them. We've not blamed them for their pollution in the buildings, in the supply chain, in the food, in the energy, in the transportation. We've said, you know what? You need a second opinion. We're going to give you that second opinion. It's about environmental health and justice. Guess what? You're living in this context. And so in this project that we did with you initially is to say, okay, we convinced Kaiser Permanente, which is one of the biggest integrated system in the country, to say all of the food they buy for Northern California is going to be from local and sustainable and equitable sources. Fantastic. How much is that? It's $100 million over 5 years. Let's leverage that then to support the infrastructure that allows that to happen. There's a food service company. They're now going to have this huge demand. Let's get them to sign a community benefit agreement with ARC, with our initiative, to hire people of color from the community, to source from BIPOC farmers and more local and sustainable farmers, to link their efforts, Kaiser's efforts, to source this with how do we feed people? How do we treat food as medicine and address these upstream things? It's a lot cheaper to feed people than waiting for them to come to the doorstep of our hospitals with diabetes and obesity and cancer and stroke. It's cheaper. It's the upstream thing that Dr. Jones was talking about. So what is the DNA here? The difference here in this ARC model is that rather than healthcare coming to rescue and be the saviors and do to the community, we're saying the community has assets, the community has wisdom, the community has power. Let's create the table where there's power sharing, and the community can say, here's what we got to bring to the table. And the hospital systems, well, here's what we got to bring to the table. And together, we can solve problems together. And so the outcome, and then I'll stop, and is the outcome of this initial initiative is a $20 million food processing facility in the East Bay that's hiring up to 150 to 200 local residents, that's sourcing from BIPOC farmers and more sustainable farmers, and having the ability to produce up to 50,000 meals a day to go out to schools, to go out to hospitals, to go out to people who are hungry, to go out as medically tailored meals, so that we can rebuild the system of food in the region that creates health, wealth, and climate resilience, because we have to solve all of these things at the same time. And that model is replicable all over the country.
Thank you, Gary, for that introduction. First, I want everyone to know that East Bay, this is East Bay, San Francisco. So this is where the ARC initiative is rooted, and we're expanding into other parts of the country. But Gary, tell me a little bit more about the collaborative effort. One of the suggestions from Dr. Jones was to build a bigger tent, to figure out who's at the table, who's in the conversation to address these intersectional challenges that we have. And very often we see anchor initiatives, which is what this is often called, being a very top-down oriented effort where hospitals themselves, they make a decision and they come up with a plan and they implement a program, and maybe communities are beneficiaries of it often. That's how anchor hospitals and other anchors have historically worked. What's different about ARC? And who's at the table?
Yeah.
And why does it matter?
Right. So it matters an enormous amount. First of all, nonprofit hospitals in the United States are required to do community health needs assessments every 3 years in order to be eligible for Medicare reimbursements and to keep their status. So already community health needs assessments assumes that the community has deficit, the community has illness, the community has trouble. All true. And the community has assets, and the community has other enormous wisdom and skills to bring. And so we need to change the frame around it. And so while in this partnership with Emerald Cities, Healthcare Without Harm had trusted relationships with healthcare anchors, Kaiser, Dignity, UCSF, other hospitals in the region. Emerald Cities had relationships with a whole bunch of community-based organizations, workforce development organizations. The Alameda Sheriff's Department that was running a farm so that people who might have been justice involved in the justice system had jobs that they could get afterwards instead of being thrown out onto the street. So there was community organizations, there were sustainable growers, there were workforce development. There's a whole cast of NGOs and community-based organizations and county governments and healthcare institutions all coming to the table together to bring their power, different kinds of power, different kinds of assets, into a collective problem-solving environment. And what Emerald Cities and Healthcare Without Harm was the holders of that table. So it wasn't the healthcare sector, come in and we'll tell you what we're going to do for you. It was like, let's do this together. Let's map out the assets. Let's map out the unbelievable amount of procurement power that these anchors have. It's more than $6 billion just in the San Francisco Bay Area. And so how can we heal the climate issue, the fossil fuel problem? How can we invest in renewable energy strategies for hospitals, for schools, for microgrids in ways that create health and wealth and climate resilience? How can we redesign the food system together? How can we redesign the transportation system together that creates jobs and opportunities for wealth creation and also builds climate resilience? So we can solve these things together if we bring everybody's assets and smarts together into the same room and not see these as separate. That's why I asked the question about social determinants and environmental health. Like in a lot of healthcare systems, the people that do environmental sustainability are not the same people that do community health, or the people that do clinical intervention, or the people that do workforce development. We need to bring it all into an integrated whole. And healthcare has been these Byzantine institutions that don't think that way. And we got to help them think that way and act that way.
So those are, you raised a lot of different issues. I don't want to pull some pieces apart one by one. One is that this conversation of coming together and us holding a table of different stakeholders with different interests. That's not easy work. It's difficult work. It's based on not being in connections with each other for decades. A lot of misinformation, miscommunication, mistreatment. This notion of trust and having to build trust is part of the work of addressing the sort of, the structural barriers to a healthy community. And particularly though, it's the value of this in my mind's eye has been that there's several health institutions at the table. You know, UC San Francisco Medical Center, a couple of other hospitals, as well as educational institutions. What I find powerful about that collective engagement is the power to move systems. You asked the question in the chat in the plenary about that bulldozer, and what do we do with corporations that are actually trying to push people over the cliff and push us, out of our own communities or what have you. The kind of collective power that this represents in terms of health institutions collaborating with not only with the community and the assets that we bring, but other institutions to shift entire sectors of the economy. The notion that that we can shift the food sector to be sustainable, to be healthier, greener, and to be inclusive, and that pay fair wages. Because part of this effort is that this facility that's just been built, the Sustainable Food Processing Center, is creating 150 union jobs.
Right.
Union jobs, and getting forward contracts into the hands of Black and brown farmers. And it's all designed to make sure that people have living wages and not the commercial food system, which is toxic, right, which is ultimately not nutritious in any way, and it pays poor wages. We're trying to change the entire sector of the economy in food, and we can do it in energy, and we can do it in housing and banking if we have the collective work of institutions coming together with communities. And I sort of raised two issues here. One is the power of this collective work and what it takes to build trust to do this. And if you had any perspective, my sense is that once you build trust, and how we did that was through learning communities. And if you want to talk about what the process is for building this table and getting on the same page and getting to the same collective vision and strategy work.
Yeah, well, there's a lot to say. Let's see. One, the trust issue is part of what Healthcare Without Harm has tried to do is build trusting relationships with healthcare institutions, because they were so ignorant of environmental health issues. We would say, here's an issue that you're going to need to deal with. And we're not blaming you, but you're going to have to deal with this. It's against your mission to be spewing dioxin into the air, to be infusing patients with reproductive toxins, to be serving food that produced with the overuse of antibiotics that makes your own antibiotics ineffective. You need to make these connections. And we're not going to just tell you there's a problem. We're going to actually hold your hand and help you solve it. And we're going to teach you that there's other people working on these things too. So some of it was like, we've just been at this for a long time to build a trust in the way that Emerald Cities has the trust in many communities, because you've been working in solidarity and other groups for decades. So there's a trust built in at different places. But then I think it's also people being willing to hold healthcare institutions accountable inside of healthcare. Like, you can't take up 20% of the economy. The only thing that's bigger is the military, and be basically a repair shop. Is that you wait for people to get really sick, and then you treat their cancer, and you treat their diabetes, and you treat their obesity. It's a failed model. And so it institutionalizes all the racial and health inequities that Dr. Jones was talking about. So there's a moment here, that a recognition that healthcare needs to be more accountable to its communities. It isn't going anywhere. It's not leaving. It has to face the fact that in one neighborhood in Boston, people are living 92 years old, average, in Beacon Hill, the white neighborhood, and a 1 hour walk in Roxbury, they're living to be 62. A 30-year differential in the same town, which has been known for global healthcare leadership. Like, that is unacceptable. And so that, as along with the COVID epidemic, which has laid bare all of these racial injustices, creates a moment, I think, an opportunity to hold healthcare accountable and to bring them forward in healing the racial inequities that they've lived with for decades. And
I know
so
what,
some of
yeah,
it's trust, some of it's accountability, I would say.
yeah.
And the point you said is like, well, how do you build that? Well, we created these learning sessions. So like everybody who's interested in sustainable food systems, come on down. Let's talk about it. Hospitals are there, growers are there, Mandela Marketplace is there, lots of people are there. Let's have another session about energy. Everybody come on down. Let's learn from each other. How do you see this? How is that playing out? How is that working from your perspective? And just having all these perspectives being held in a container that raises the resonance of the group. It's very important. The facilitation is very important in these kind of situations. And you do a great job of it.
And,
So did
and
Tara Mark.
I think it's powerful. The whole idea that we all come from our own silos and our different perspectives, and breaking through the barriers really requires just open, honest, free space where we can learn from one another, get out there, kick the tires, see what a cooperative is, because the community's talking about co-ops. What's a co-op? And kicking what are gardens? What does urban farming look like? What does it look like on the inside of a health institutions? What are their bottom lines? How do we begin to reconcile our different worlds is critical. And I think one of the major accomplishments and has been the point that you raised, and I think the point that Dr. Jones raised is breaking through myths, right, about how we perceive our communities, to perceive communities of color in particular, that they're sick, or they're deficient, because that is the health framework just generally. How do you deal with sick people? How do you deal with sick communities? And finding out the strengths and the muscle that we bring to this work and the assets that we have been doing this work. We've just been doing it alone, and recognizing that's a whole different framework of healthcare, and what you can achieve together.
And it's also saying they have a broader healing mission. It's not just about treating people, it's about healing communities. It's about healing our relationship to the planet. And so leveraging their purchasing, leveraging their investments in the communities that need it the most, leveraging their workforce development. So they're bringing more people of color into their workforce, not at the lowest levels, but at a higher levels, and even leveraging the policy, so that the political capital that these healthcare institutions is enormous. They're the biggest employers in most states, many states. And so some of the work that we've started to do in a number of states is getting the healthcare institutions together into an alliance in the state, and then having them advocate for policies that raise up the environmental justice concerns of those groups, many of them Kresge grantees, in those states. So, in Washington State, there's a whole new Healthy Environments for All Act, HEAL Act, and it's all about raising up the recommendations of this whole environmental justice task force to create a council, to adopt guidelines, to provide technical assistance to communities, to invest in those communities, to even get the healthcare institutions to not support some kind of cap and invest bill because it's about disproportionate impacts, and because that's what the environmental justice community was asking. So getting healthcare to be accountable not only at a community level, but a policy level. So the policies that we're pushing in states are also representative of healing racism, of healing climate, of healing the economic inequities. I mean, there's so much opportunity that we're just scratching the surface still on the opportunities that we have. What if we link schools and hospitals together in their purchasing power? And universities and municipalities. That's starting to happen around food. What if we do it around energy? There's so many opportunities to grow this collective impact if we take the intersection of climate, health, and equity together. And that foundation's got to do that too. They've been in their own little boxes that have weakened the entire movement. That needs to be fixed as well. That needs to be brought together in an integrated whole.
So I wanted to see if I have a zillion different questions in this. You can take this conversation on forever, but I did want to see if there are any questions, and I don't know how to best answer people can speak directly to raise a question, or whether I can ask our participants questions, because I have questions for you all if I'm able to navigate this. But my question to our participants in this workshop is, what have you seen as some of the institutional barriers to community health and climate resilience? Are there examples that you can offer us about what are some of the challenges that health institutions need to address, or we need to help health institutions to address issues of racism and poor health and disproportionate impacts on climate and economic opportunities? So it's a general question, and didn't know if we had a way we could get people to show up in this conversation.
It would be good. We have 15 more minutes. It'd be great to hear from other people. What's working, what's not working, what models can you share with us?
So is there someone in the Shea community that can tell us how people participate? The chat is one vehicle. Is there a way that people can just be in conversation?
Share your video. We can do that.
Hey,
okay, Elizabeth, yay, go ahead.
I can answer Denise's question, but I clicked on the button that says ask to share video and audio, and it worked. So other people could do that.
Okay, where do people find that?
It's a big red button in the upper right is where I saw it.
Okay.
And I could ask another question, maybe while people are finding their way in. I'm curious what opportunities, Gary and Denise, you see in infrastructure bills, which supposedly are going to have a care component and stimulus funding. Is what you're doing ready to be a conduit for that kind of millions, billions, trillions? And what would you need for it to be?
I mean, I'll start. One of the things that we think is really crucial is to build resilience in communities and in the healthcare infrastructure. So, and that especially for safety net hospitals and rural hospitals, which are the one anchor, the one safety net in many communities. So having the infrastructure drive the economy toward a low carbon renewable energy economy, having renewable energy power facilities that helps to build jobs to make that happen. That was what we learned in Katrina, is that when the grid failed, the backup systems were in the basement. They were diesel backups, and all the hospitals failed. Same in New York in Sandy. So sort of building the infrastructure for resilient healthcare, and also the kind of systems that would allow communities to operate in extreme weather events, sea level rise, all these things. There's infrastructure that's about climate resilience and community resilience that would be shovel ready, as they say.
Yeah, and I've been able to see a couple of different tributaries into this. One is the Environmental Climate Justice Organization really pushing for resilience hubs in communities as very specific examples of how we can build that, and it addresses extreme heat conditions. The other is, I see the new Secretary SBA, Director of SBA. She comes out of California, Elizabeth Guzman. She's very strong on anchor strategies as a part of an economic recovery strategy, a COVID recovery. She was doing it in California for the state before I think she finally got her appointment as secretary. So I think we're going to see some movement out of SBA in this regard. I believe that there is yet to be a really coherent and strategic approach about being place-based, anchors, place-based initiative that's really working at the intersections in the way that we're doing it. So there'll be pieces of money moving in various places that could potentially be leveraged. And we are working with, hopefully some other foundations to replicate this in other communities.
Yeah, like there's programs that you can do weatherization, energy efficiency, better windows in people's homes, and also detox the home around the pesticides and the moldy carpets, so that you're actually both addressing energy and weatherization and job creation, but also asthma in kids. So these are linked strategies, the things we need to do, linked strategies that do these things together. Others?
So I'm going to go to Matt and then Lori. Hi, Matt. Please introduce yourselves as you open up.
Absolutely. So I'm Matt Vanderslice. I'm with an organization called BARHI, the Bay Area Regional Health Inequities Initiative. So it's a coalition of the 11 local public health departments of the Bay Area that came together to focus on the intersection of equity and health. And so we do work that's transforming the public health sector in the region and working on the social determinants of health, the inequities, working on other actors, so the state legislature, other public agencies, etc. And we've been building out our climate program. I'm really excited to connect with you. I think that there's some future conversations we should have, particularly because of your Bay Area work and ways that we might be able to intersect with that. I think particularly leveraging the health department space, because they are similar to the healthcare providers. They've got a lot of overlap. So there might be some really interesting ways to integrate our programs there.
Absolutely.
So, yeah, really excited.
Absolutely. I mean, part of the healing that has to happen here, and Dr. Jones talked about it, is the healing between public health and healthcare. So that there's an integrated approach. Public health's been like the poor cousin for the last century, and we need to build that up, because ultimately we're talking about a public health strategy for how do we build resilient, equitable communities. It's not just about treating people who are really sick anymore. So that marriage of public health and healthcare has to happen too.
Mm-hmm. That's absolutely right. And I think a lot of the silo breaking down that you're describing in the healthcare providers is work we're trying to do on the public health side, where you have the same, siloed, very defined sets of money. We can use our cash on tobacco prevention, but if there's not a bucket of funding for climate action, for resilience work,
right,
we're stuck. So a lot of that's one of the fronts that we're working on, is to expand state funding so health departments can be engaging in resilience as it affects all of the other issues that they work on.
Great. So I'd like to get to, thank you, Matt, Lori's question. I know we're running out of time, but they may give us a little extra. Hi, Lori.
Hi, can you hear me?
Yes. Okay. Who are you and where are you from?
I was until recently the head of the Michigan Climate and Health Adaptation Program, which is the CDC funded program for health adaptation. I just recently retired. I'm at Michigan State University now. But my question to you, Gary, and I really appreciate the work you've been doing over the years, is when I was working with our health department, we were trying to approach some of the hospital systems in Michigan to engage with us. And they were for profit. Even the big one in Detroit, which I won't name, is now for profit. And that seemed to be a real barrier because of the whole reimbursement issue. You mentioned nonprofit hospitals have the incentive of having to do community health assessments, but I wondered if you had any thoughts about how to engage the for-profit part of healthcare in these conversations.
Yeah, I mean, what we've seen, and it's tougher, there's no question about it, because they're driven by money. There's no pretext. So what we found is that there's some vulnerability because there's such a broad movement in the corporate space around corporate responsibility, ESG, environment, social, and governance. And so sometimes leveraging, not necessarily from a public health department, but from community organizations, leveraging through shareholder action or through other things. I mean, that's a little aggressive, but the point is that they're feeling that they need to feel some heat.
Aggression is a good thing in certain
It's positive aggression.
Power shifting.
Yeah, they need to feel some heat, like they have to deal. We found that with the pharmacy chains. They didn't particularly care, but we around getting rid of mercury, but we had shareholder action against them, and then they felt like they had to deal with it, and then they dealt with us, and they said, well, you're not too bad to deal with. So I think there's some political pressure that has to be brought to bear, tougher on the for-profits, but also we've been able to say a lot of the stuff we're talking about, you're going to save money. Oh, say, oh, well, you're going to save money. Well, in that case, like that.
Well, I think any documentation that you can provide on the money end is probably a good way
key.
of starting the conversation. I know that there's been interest in sort of evaluating the costs of climate harms and also the savings of prevention of, you mentioned, for example, asthma. And people
I mean, we have to
like
internalize these costs, right? That's another fundamental problem. The externalized cost of the fossil fuel, toxic chemical, industrial agriculture economy is invisible. It's felt by communities and it's paid for by communities, but it's not on the balance sheet of any of these companies. And those internalized health costs and racialized costs, they need to be explicit. They need to be exposed, because otherwise, it's somewhere else. It's not part of my problem.
Elizabeth, what part of the system do you work?
Well, I'm the co-director of a group called Climate Interactive. And so we started out with a global perspective on climate change. I shifted over the years because it seemed like the climate problem was insolvable if it was only about CO2. And that most of the time in the climate space, people were not taking account of all the possible benefits, like you all are talking about, of jobs and better food and more resilience. So first because I'm an analytic person, we did a lot of research that tried to just add up all of those co-benefits and make the case, as the World Health Organization did 2 years ago, that the costs of being on track for Paris are offset by the health savings of that same path. So trying to make that case, but what we came to see was that it's just an exercise in accounting that's not going to lead anywhere unless you can do what you all are describing of reshifting relationships and spanning different silos, of whether they're budgetary silos or decision-making ones. So we've been studying what we call multi-solving, which I would say is exactly what you all are describing. Just really fascinated by, they're still rare, but these bright spots where people do find ways to work across these silos. And our big curiosity is like, what's different about those efforts? Where have these efforts been able to go forward where so many other people can't? And a few of the things we find are that they start small and they're iterative. They're huge investment in communication and listening. There's some kind of flexibility about optimizing for many goals, not just maximizing for one. I'm sort of testing whether those line up with how you feel you're working.
Yeah.
It definitely sounds like that to me.
I would say just a couple of things, that it is an iterative process and we learn as we go. One thing is that we look for projects that are intersectional. So if you want to just work on economic development, we're just not going to have hospitals buy pens if it's not going to address climate and health.
Yeah.
Right. So what are those particular efforts that have an intersectional, as you say, multi-solving impact? So that's a very unique approach. Secondly, a lot of it does come back down to accounting. Those are the challenges that we're fighting. For example, how much does a hospital pay for food? We know that this is going to address climate change in terms of how we're dealing with, growing food. We know it's addressing health. We're creating jobs, but now they're saying the price of celery, okay, is going to be a barrier. And I'm not kidding you. It is like, 4 cents or 10 cents a stalk is, breaking through these intersectional challenges. So you can't get rid of accounting, no matter how good the idea is and the strategies. It's going to come down to the business case that can be made.
And then you have to, and the business case is a broader business case, right? So if we're feeding people, they're not necessarily coming into the hospital because we're trying to prevent them from getting sick in the first place. That's what all this is about. I think there's so, as you say, there's so many solutions that are multi-solving. We just we need to, find them. I think there are many out there, but also scale them across the country with a whole set of partners. I mean,
we'd love to see whatever you've been able to do in terms of having your studies. We'd love to be able to share that. And didn't know.
Yeah, I'll follow up with both of you. I would really love to hear more.
And that as well. And I guess Brianna, you're getting ready to tell us to get out of here, right? All right.
Not quite as coarsely as that, but this was a super interesting conversation. Thank you all for participating. The main stage is open with DJ Asha playing.